Hi everyone, thank you so much for joining me today. My name is Amira. I'm going to be talking about domains of medicine and data types 3. So this is just a little bit of information about me if you're interested. Um, the main thing on this slide is my email. If you have any questions, please feel free to email me. I try to respond within 48 hours. I have no conflicts of interest. And these are kind of just the topics I will be covering today. We'll just do a quick review of health data. This was already introduced in the Data Types 1 lecture. And then we'll just kind of delve deep into psychiatry and personalized medicine. So health data, we already covered this. I'm going to go over it just really quickly, just as a refresher. There are all kinds of sources of health data. Initially, it was mainly kind of from hospitals and possibly health agencies, but now we kind of have this really wide array of where we can actually get health data from. And devices is becoming one of the really new and very greatly utilized areas that we get data types from. There are a bunch of ways that you can categorize data types. One of the really useful ways that is usually referred to in medicine is structured and unstructured data. So structured data is standardized data. It's very easy to transfer this kind of data between health information systems. So for example, like age, gender, blood test results. Unstructured data is not standardized. And in order to put it from one health information system to another, there has to be a lot of pre-processing steps. So this is like raw audio recordings of a patient encounter, or emails, or charting notes. So those are all examples of unstructured data types. And then another way of categorizing data is in terms of quantitative data and qualitative data. So quantitative data is basically numbers. Again, these are very easily transferable between health information systems, whereas qualitative data tends to be non-numerical, usually observational, and again, transferability is a little bit difficult when you want to put it from one system to another. And this was kind of introduced at different points in this lecture series. But again, I just want to make sure we're all on the same page. So in terms of the clinical flow, like what actually happens in clinic or in hospital when we see a patient? The first thing we do is we want to talk to the patient. So we get a little bit of the history. This can be what the patient actually describes to us. Sometimes if there's patient's friends or family with them, we like to get some collateral information. And then we move on to the physical exam. So during the patient encounter, once we listen to their story or what their family or friends are concerned about, we move on to the physical exam. And this is supposed to be kind of an objective way of a physician to assess a patient. So this can be physical. So for example, doing a cardiac exam in a patient who has chest pain, or this can be just purely observational. So in terms of general appearance, how they're speaking, what they're wearing, does it look like that they're sick? Once we do physical exam, we can move on to investigations. So these would be things like blood work, imaging like x-rays, CTs, MRIs, ultrasounds, and other modalities, just depending on what the patient's coming in with. And at the very end, we take all of this information and we try to create a preliminary diagnosis. And then again, just very quickly, just the difference in terminology between symptoms and signs. So in medicine, symptoms are things that the patient describes to you. So here's an example. I have very severe chest pain on my right side under the ribs that started yesterday afternoon and has been getting worse. Signs would be things that you observe in the patient. And these are supposed to be more objective. So this is an example. The patient is febrile, so they have a fever, and is observed to have scleral icterus. So when you look at their eyes, when you look at the white part, instead of it being white, you see it as yellow. So these are supposed to be more objective. These aren't like the patient can't lie about these, because as a physician, you're able to see these during the patient encounter. So those are considered signs. On our next topic, what we're going to be talking about is psychiatry. So an example of a symptom in psychiatry would be, for example, I have been feeling very sad. I've been crying more than usual. I don't find enjoyment in the things that I normally enjoy. So this kind of sounds like depression, but what are the signs? What can I observe in the patient? And when I look at the patient, I would observe, for example, the patient appears poorly groomed and has a flat affect. So what that means is they might be just dressed not well put together. They might be in sweats. They might be actually dirty. You might smell a scent that looks like smells like they haven't showered in a long time. And a flat affect is like they're very monotone. They're not very expressive. They just kind of like look at you with like their tired face and they just say words and they're not really having any facial expressions or anything like that. So those are observations and they're supposed to be objective. In psychiatry, it's a little bit difficult because there is some physician bias that plays into it. But again, it's supposed to be a little bit more objective than a symptom. So in psychiatry, let's just define it first. It's a medical specialty devoted to the diagnosis, prevention, and treatment of mental disorders. And a lot of times these mental disorders, they're not provable with like one single blood test or one like objectively measured factor. So for example, in like hyperthyroidism, you can measure someone's TSH. And if it comes back really low and they have all the symptoms that describe hyperthyroidism, that's almost like the TSH is the confirmatory test that tells you, yes, this is what they have. If someone is very sick and they have this cough and it's been there and for a while and they have this fever and you do a chest x-ray and the chest x-ray looks like they have pneumonia, again, that's like the telltale sign that yes, they have pneumonia. We've confirmed it. In psychiatry, a lot of the mental disorders aren't like that. There isn't like a telltale test that you can do that confirms your diagnosis. You have to rely very heavily on patient experience, collateral observation, so that would be the stuff that their family and friends tell you, and then your personal observations in the clinic or in the hospital. So going back to that kind of clinical workflow, we are supposed to do history, physical exam, investigations, take this all together to make a diagnosis. But in psychiatry, it's very heavily weighted on the history portion. It's very heavily weighted on what the patient tells you, what their friends and family tell you. The physical exam, you can do a neurological exam to just rest assured that there isn't anything organic going on. But a lot of it has to do with what you see. So the general observations, what can you see that the patient has been saying, or the way they're groomed, or the way they look, the way they smell. So there's kind of this sort of standardized way of doing a physical exam, not really physical, um, a physical exam on a psychiatry patient, and it's called the mental status examination. And it kind of comes to four categories. So the first one is general observations, then we have thinking, emotion, and cognition. So in terms of general observations, you look at what they actually look like. So their hygiene, how are they dressed? Are they wearing a lot of jewelry, a little bit of jewelry? Are they wearing an excessive amount of makeup? Are they wearing no makeup? Their speech. So are they speaking super fast? Is it really hard to keep up with them? Or are they really slow? Are they yelling at you? Are they whispering? Their intonations. So are they like saying things louder than other things when it's usually not like that? Their behaviors. So eye contact's a really big one. Mannerisms, their hand gestures, any aggression that you can see underlying, and cooperativeness. This one's a little bit difficult, but if you're kind of asking them questions and they're difficult to speak with, that would talk about their cooperativeness. Their thinking can also be there could be a little bit of bias just based on from physician to physician, but their thought process. So when they try to describe something to you, does it actually make sense? And there are all these kind of terms to describe thought processes. Thought content. So for example, like what are they actually telling you? Is it future oriented? Does it sound like they're suicidal? Are they going to kill someone? Are they very fearful of something? And lastly, perceptions. And this is really big for things like schizophrenia. Are they hallucinating? Do they hear or see things that other people don't hear or see? And then delusions is just like it's like a belief that there's something there that isn't. So for example, being very paranoid or feeling very like grandiose, thinking that you're literally like the king of the world. The third category is emotion, so their mood. And this one's not really something that you can observe. This is something that you would ask the patient, how are you feeling? And then the affect type. So the physician's description would be, do they look anxious? Do they look euphoric? Do they look very angry? And then you would see how this correlates with what the patient's telling you. So let's say, for example, the patient tells you, yeah, I'm doing great. I'm very happy. But as they're speaking to you, you can see that their eyes are tearing and they don't look happy at all. And then lastly is cognition. So this is just like a very basic, like, do they actually know where they are and what day it is? So you'd ask them kind of just orientation questions. What day is it? Where are you right now? And you can even ask them just like, who's the Prime Minister of Canada right now? In terms of memory, there are different types of memory tests that you can use if you'd like. And then lastly, insight and judgment. So this is like, does the patient actually know that there's something wrong with them, or do they think they're completely normal? So that's kind of like the closest we can get to standardizing a physical exam in psychiatry. In terms of diagnoses, there's this very great manual called the DSM-5, which stands for the Diagnostic and Statistical Manual of Mental Disorders, and it's the 5th edition, so DSM-5. And it's mainly used for the assessment and diagnosis of mental disorders. And it's using very specific criteria, and I'll show an example of this later on. But one very important thing to note is that these mental disorders, they're just descriptions of the mental disorders. There's no information or guidelines on how to treat the mental disorders. And this is an example of what a DSM-5 entry would look like. So here's an example of something called depersonalization / derealization disorder. And the code is 300.6. And the thing with the DSM criteria is they always have to meet all major criteria. If they don't meet all major criteria, then they do not qualify as being diagnosed with this mental disorder. So in like a nutshell, depersonalization or derealization disorder, it's almost like, it's like you're playing The Sims, but in real life. It's like you're the sim character and you're watching yourself do these things and you feel like what you're seeing isn't really real and like it's all a simulation, like none of this is happening and you don't really have control over the things that are going on around you. You're just like observing. So this is the first criteria. You have to either have depersonalization or derealization experiences. So depersonalization would be like being that outside observer. Like you're just observing your thoughts, your feelings, what you're doing. And derealization is thinking that everything around you is not real. Like you're just completely detached from reality. You see these things around you, but you're convinced that what you're seeing is not real, almost like the Matrix. Section B says the reality testing remains intact. So we have to make sure that this patient, they're actually seeing the things around us. They are aware of what's going on around us. They just don't believe it's real. So if I'm like, what am I holding in my hand? And I'm holding a pen, they're able to say, yeah, you're holding a pen. They just don't believe it's real. Section C, D, and E, they're all kind of like the same for almost every mental disorder. The first thing is that it actually has to cause them distress or impairment. So this isn't just like, oh, you have a fleeting thought that you live in the Matrix and this is all a simulation and it lasts a few seconds and it goes away. It like significantly causes distress in your life and you cannot function in society anymore. Section D, it's not attributable to any substance use. So, this patient doesn't think they're a sim character because they're doing LSD or MDMA or shrooms. Like they're completely normal. They're not using any drugs right now. And the last thing is it can't be described by any other mental disorder. So this is kind of like, make sure you review the other mental disorders before diagnosing them with this. So anyways, that's an example of what a DSM-5 description would be for a disorder. And in this case, it's a depersonalization, derealization disorder. So what does AI have to do with psychiatry? I looked up like a whole bunch of papers, and I actually really liked this one. It was just like really a survey, um, asking psychiatrists what they think of AI in psychiatry. So the survey respondents were 791 psychiatrists from 22 countries all around the world. And I'm going to show like a few of the results, but like in general, about 4% felt that future technology in AI would make their jobs obsolete. So they don't think AI is going to take over. And only 17% felt that future AI or ML was likely to replace human clinicians from providing empathetic care. So once again, they don't think AI is going to replace psychiatry. However, 1 in 2 psychiatrists, so that's about 50%, predict that their jobs would be substantially changed by artificial intelligence or machine learning tools. And here's just kind of like a visual description of this. So in terms of like how impactful AI will be in their jobs, most people say they'll at least minimally influence it. The minimal influence, about 42% said it, moderate influence, 47%. And then how long will it take for AI to actually replace documentation for the patient? So not replacing psychiatrists, but just replacing documentation section. And almost everyone said within the decade. So that's pretty interesting. All these like psychiatrists genuinely think within the decade, AI is going to be integrated into psychiatry, probably in the form of documentation. And these are just like a summary of all the results they found. So again, providing documentation, most people said it's very likely that AI will play a role in this. Whereas providing empathic care to patients, most psychiatrists said it's very unlikely. So to answer the question, how can artificial intelligence be applied to psychiatry? I felt that that paper did a really good job at identifying a whole bunch of different ways that it can be used in psychiatry. So the very first one that a lot of psychiatrists felt would be impactful is providing documentations. So updating medical records, charting on patients. There are also other things, for example, providing treatment plans, deciding whether a patient is safe to go home. Do they have to stay in hospital or can they go home? Establishing prognoses. How will their disorder progress in the future? Are they dangerous? Are they going to kill someone or are they going to kill themselves? Reaching diagnoses, and this is greatly with the aid of the DSM-5 criteria. Performing that mental status exam. So that one slide that we spent a super long time talking about the physical exam of psychiatry, AI could potentially just replace humans and it can do the mental status exam in its place. And then lastly, obtaining a medical history. So as you can imagine, just from data types, we have the qualitative and the quantitative, we have unstructured and structured. So a lot of data types in psychiatry, unfortunately, are very unstructured. They're very messy. These would be things like patient surveys, audios and video recordings, clinician notes. And there have been some attempts to standardize this documentation. The mini mental exam is one example that can very easily be converted into checkboxes that can be standardized. Then there's the patient health questionnaire, the QH9. I didn't really talk about that, but we did talk about the diagnoses, so the DSM-5 criteria. There's also some use of imaging, so it could be like the encephalogram, functional MRIs, and possibly some other types of imaging. And then lastly, use of social media. So remember that data type. Data can come from your own personal devices. Psychiatry has shown a lot of work of AI using things like social media and the use of personal devices for diagnostic and prognostics. And this is just like an example of what a clinical note would look like. And this is very real. Like this is what a lot of hospital notes look like. So a patient actually just a couple weeks ago came into Emerge, and she was just having a full psychotic breakdown, like just completely crazy. And of course, whenever we see a patient, we have to document it. And this isn't the exact documentation. This is for someone with pneumonia, but this is exactly what it looks like. You just have this paper chart, you have to physically write on it, and that's your patient encounter. That's the kind of documentation you have of that encounter. So very messy and very difficult to kind of incorporate into some AI system. But in terms of work that has been done in psychiatry using artificial intelligence, this one's pretty interesting. So they basically just used a smartphone to their advantage in terms of basically keeping track of a patient. So this isn't necessarily for diagnostic purposes. Based on what I read, it sounds more like keeping track of the patient. And they do it on many different levels. So actually just physically, like, where is the patient? Are they moving around? Did they just like go across the country? Um, there are just like integrated surveys that they can use if they're feeling a certain way. And then lastly, like sleep activity and then physical activity via the phone. There's another AI study that I'll talk about in a second, but I'll first define what schizophrenia is. In a nutshell, schizophrenia is like you hear and or see things that other people don't hear or see. It's very distressing. It makes you lose touch of everyone around you and you can't function in society. This is the official DSM-5 criteria for it. And as you can see, there are a lot of different things that you have to fulfill, but that's what schizophrenia is. And there's this really cool paper. Actually, the main author, Dr. Kalmadi, is actually a postdoc here at the U of A. He works with Dr. Russell Greiner currently, but this is one of his works. So basically, he used a functional MRI, so fMRI, and the resting state would be used to classify schizophrenia. So essentially, just like a little bit more information on this. So the resting state fMRI data collected, all the patients were treatment naive patients, so patients who were not being treated with antipsychotics already. And they had to meet the DSM, in this case, the DSM-4 criteria for schizophrenia. And they developed this ensemble model called EMPhaSIS. And just the way it's spelled, it stands for Ensemble Algorithm with Multiple Parcellations for Schizophrenia Predictions. And I won't go too much into the details, but it's a very interesting paper. And it's an example of how imaging can be used with AI in psychiatry. Another study was used to detect bipolar disorder symptoms. So bipolar disorder, just want to make it clear, it's not like someone who is happy one second and then mad the other second. That's a different, actually more of like a personality disorder. But bipolar disorder, there are two types. There's bipolar 1 and bipolar 2. And essentially bipolar 1, it's mostly defined by its manic and its depressive states. So bipolar 1 would have really manic states and then possibly some depressive states. And a manic state is like a state where you just basically go manic. So you're very, you don't want to sleep. You might have these delusions of grandiosity. You feel like you can rule the world. You speak really fast. You're feeling really good about yourself, and you just do all these things that you normally wouldn't do. And then another second, well, not another second, but after some period of time, usually weeks, you'll enter this depressive state. And in that state, you'll have a depressive episode. And again, that depressive episode will last days to weeks, where you feel symptoms of depression, you'll feel unhappy, you won't find enjoyment in things you normally find enjoyment, you won't want to leave bed, you don't want to eat, you might have difficulty sleeping, or you just sleep too much. And bipolar 2 is similar. It's just mainly characterized by the major depressive episodes. It, again, lasted days to weeks. And then the manic episodes might just not be as severe. So they'll be just like a little bit manic, but not extremely manic. So you might spend a little bit more money than usual. You might have a little bit less sleep than usual. You might be a little bit more hostile or irritable than usual. So that's bipolar disorder. And this group Interestingly, use the keyboard on your smartphone to detect periods of depressive episodes and manic episodes. So you can imagine when you're having a manic episode, it's like your brain is racing at like 100 miles per hour. And if you're going to text someone, like you just have all these thoughts and all these things that you want to let them know. So you're going to type a lot faster, you're going to make more mistakes, you're going to send it before proofreading, and you just do that and you do a lot of it. So that would be like a manic episode. And then a depressive episode would be like you isolate yourself from everyone. You don't want to text anyone. You don't want to see anyone. If you do text anyone, you're going to do it really slowly, and you're only going to send like one sentence or even one word text. And that would be like the keyboard sign of having a major depressive disorder. So very interesting on how by effect the system that they uses AI to find kind of these patterns. So that kind of concludes psychiatry. I guess I didn't delve too deeply into it, but the next thing I just want to touch on is personalized medicine. And just so you know, there's this Department of Precision Health right here at the U of A. It's a signature area, and its efforts are to understand, diagnose, and treat diseases through advances in technology. And the whole purpose of it is to have customized, unique precision treatments. And they're basically just taking advantage of the fact of that we live in a very personalized time. So before, we looked at patient-centered care, and that was a very big thing in medicine. But now we're actually starting to transition to something called person-centered care. And it's the idea that the patient, not just a patient, but it's a person who lives in society and who has all these other things going on outside of their disease processes. So person-centered care is the more newly accepted term. Um, and we have all this information from people. And I'm going to talk a little bit about genetics too, because that's like an insane amount of information just on one person. But just some examples of how we can use personalized medicine. I'll just introduce the idea of diabetes. So this is just, I won't go into too much detail, but basically like you'll eat something, the blood glucose in your bloodstream will increase. Your pancreas is supposed to release insulin. A whole bunch of your tissues respond to this insulin so that it can actually metabolize this glucose and use it. So it'll either use it right away or it'll store it in the form of either glycogen or adipose. So there are really three types of diabetes. Type 1 is the type that can't produce insulin. For some reason, the pancreas does not produce insulin. Type 2 is a reduced ability to respond to insulin. So you have enough insulin in your body, but your tissues are becoming resistant to it. They just aren't responding to it. And then gestational diabetes is a reduced ability to respond to insulin, specifically during pregnancy. And the reason for this is just because of the different hormones that the placenta releases during pregnancy. It just makes your body a little bit more resistant to insulin. The result of any of these is that you do not have the ability to metabolize glucose as you normally would. And the consequences of diabetes, although it's very common, the consequences are awful. Um, the natural course of the disease will cause diabetic nephropathy, so kidney failure, diabetic neuropathy. You start to lose sensation of your fingers and your toes, and then it'll turn into your hands and your feet. Diabetic retinopathy, it literally can cause blindness. That's a natural progression of the disease. Hypercoagulability of the blood, you're more likely to develop clots, and the reduced ability to heal. So if anything happens, if you get a cut, it'll just stay open for a very long time, and you have an increased risk of infection in that case. You can also have a lot of complications during diabetes when it's poorly controlled. So diabetic ketoacidosis is an example, something called HHS, hyperosmolar hyperglycemic state, hypoglycemia, and sepsis. And again, it's a very common thing. So 29% of Canadians live with diabetes or prediabetes, and 1 in 10 pregnant women are diagnosed with gestational diabetes. People with diabetes are 3 times more likely to be hospitalized with some sort of cardiovascular disease. 12 times more likely to be hospitalized with renal disease, and 20 times more likely to be hospitalized for a non-traumatic lower limb amputation. So you get one of your limbs cut off, not because it got crushed or because you're in an accident, but simply because you have diabetes and you had an ulcer that didn't heal, and now you have an infected or necrotic foot. And then of the people who get strokes, 30% are diabetics. 40% of people who have heart attacks are diabetics. 50% of people with kidney failure who require dialysis are diabetics. And again, 70% of the people who have amputations for non-traumatic reasons are because of diabetes. It's a leading cause of blindness, and diabetes can reduce lifespan by 5 to 15 years. So not to scare anyone, but this is a very significant disease. But like so I just talked about like diabetes is an awful thing. We need to be really careful. It causes all these issues. So the best way to deal with this is to prevent it. And this is a whole idea of preventative health and primary care. So who's at risk of developing diabetes? So for type 2 diabetes, one thing that you should consider is ethnicity. So there's an increased risk in African, Arab, Asian, Hispanic, Indigenous, or South Asian descent. Their age, you're more at risk if you're older. Level of education, they found that people who have lower levels of education, like high school or less, are at higher risk of developing diabetes. Lower income, so again, that's socioeconomic status, increased risk if you have lower income. Physical activity, if you have a sedentary lifestyle, as in you don't move, you don't exercise, you're at increased risk. Your weight, so if you're already obese and you don't have diabetes, you're at increased risk of developing it. And lastly, they found that there's a lot of genetic links between type 2 diabetes and just like family history, and there's just some sort of genetic link with that. So I already kind of showed this in one of my other presentations, but it's just interesting that they developed this system. So IBM Watson and Medtronic developed this system that can monitor glucose levels and automatically deliver insulin. So insulin delivery, type 1 diabetics definitely need insulin. And a lot of type 2 diabetics kind of later on in their diabetes, they can kind of convert into a little bit of type 1. So they become a mixed type. So a lot of people actually rely on insulin delivery to manage their diabetes. And the system allows it basically measures their blood glucose and it automatically delivers insulin. And they don't have to do anything. They just kind of have the system, it's attached to them, and it just does all the work for them. So that's a really significant load off them and a lot of responsibility offloaded off them. There's this also a study called the Deep Diabetologist. Um, and it's kind of like learning to prescribe hypoglycemic medication, so people who tend to have hypoglycemia, and it uses recurrent neural networks to do this. In terms of surgeries, some problems can actually be fixed surgically, um, but a lot of times, like surgery actually does pose a lot of risk to the patient, and you really have to think about, will they benefit from a surgery? Or will they not? Like, is the benefit of the surgery greater than the risk of not having surgery? So an example would be like an acute appendicitis. So if a patient looks like they're really sick, and just based on all of their clinical presentations and all of the signs and all of their investigation results, if it looks like their appendix is going to burst, they're probably going to die. So the benefit of getting an appendectomy, a surgery to remove the appendix, is favorable in this case. So no surgery, they'll probably die. Surgery, they might have like some reaction to the anesthesia, they might hemorrhage, they might get an infection, but all of these risks are quite low considering the fact that they might die if their appendix bursts. But there are kind of some like more gray area things. So for example, let's say someone has chronic renal disease. So once your glomerular filtration rates dips below a certain level, and the patient's symptomatic, they'll need to have dialysis. And dialysis can either be hemodialysis, where their blood's filtered with an artificial machine, or through peritoneal dialysis, where the peritoneum is used as some sort of filtration system. And going through dialysis really sucks. Like, patients do not like it. It really sucks to have to do dialysis. It's this burden on your life, and it's really, really difficult to have a job while you have dialysis as well. So it significantly impacts the patient. And the only way to cure chronic renal disease is, you can't really cure their kidneys, but you can give them a transplant. And for the most part, the transplant isn't replacing a kidney. It's almost like you give them an extra kidney, so they have 3 kidneys. So dialysis, in like medicine talk, it's a very like low risk complications, but it's very morally draining for the patients. They hate it. For transplants, the first one is the risk associated with undergoing surgery. So hemorrhage, infection, all of those things. Then there's a second risk, and it's a risk of transplant rejection. And that's like the really big one, where it's like there's all these studies to try to figure out, is this patient actually going to accept this transplant, or is he going to reject it? So there's this interesting study, can we improve predictions of adverse surgical outcomes? And they use this machine learning technique to figure out whether or not a patient is going to reject or accept a transplant. And same thing with here, deep learning for improved risk predictions and surgical outcomes. So are they actually going to benefit from the surgery? And this is, sorry, I think I quoted the wrong thing. This one's just surgical outcomes, not necessarily kidney transplants. This one's just how well are they going to do from the surgery. And then this one, this article is talking about what are the actual outcomes of the surgery with kidney transplant, and they use artificial intelligence to try to determine this. So the last kind of section of this is genetics, and this falls under the umbrella of precision medicine. But before I go into it, like, I'll just do a very quick, like, let's just make sure we're on the same page. So like, when we're referring to DNA, we're like almost always referring to the genomic DNA that's stored in the nucleus. The standard number of chromosomes for humans is 23 pairs for a total of 46. 44 of these chromosomes are autosomal, and 2 of them are sex chromosomes. So if you're a woman, you have XX. If you're a male, you have XY. That's a standard. There are all sorts of variations of this. Chromosomes are made of double-stranded DNA. They're wrapped around these histones, these little protein histones. And DNA itself operates off of 4-letter codes. And these are, we call these codes bases, and there are over 2 billion bases in the nucleus. They're adenosine, thymine, guanine, and cytosine, ATGC for short. The A's pair up with the T's and the G's pair up with the C's. The mitochondria, and you have a whole bunch of mitochondria in each cell, and the mitochondria has its own DNA. And when I was like making the slide, I don't know, I just forgot for 2 seconds that the mitochondria has its own DNA, and I just thought that was just so crazy. And like, you know, like the endosymbiont theory, like, wow. Anyways, when we're talking about DNA, we're not usually talking about this unless we specifically say mitochondrial DNA. When we talk about DNA, we're talking about the genomic DNA, which is found in the nucleus. And like, DNA is very important. This is the central dogma of biology. You have all this DNA. This is like the blueprints of everything that happens. So just imagine, like, we all started as a single cell, and that cell had to somehow become this whole human. So all the instructions of how to go from a cell to how to become an entire human is stored in the nucleus. So we want to protect this, you know, we want to protect these codes. So the way we actually act, the way we actually make useful proteins and useful actions for the cell is by first transcribing the DNA. So this is a transcription step. We go from DNA to RNA, which is single-stranded. This RNA leaves the nucleus, it goes into the cytoplasm of the cell, and we have translation, where you actually use these codes to make proteins. And the proteins are the things that actually do stuff. And there are all kinds of stuff it does. So it can be enzymes, it can signal different cells, it can like join with other cells, it can attach to other cells. The actual proteins are what do the actions. And this brings us to kind of just the studies of each level of this. So when you're studying DNA, you're studying genomics. When you're studying RNA, you're studying transcriptomics. When you're studying proteins, it's proteomics. And then you can get to like metabolism and how all these things interact, and that brings you to metabolomics. So the Human Genome Project was like this whole thing that happened kind of in the early 2000s. And it was like information explosion. It like just revolutionized everything, and everyone really freaked out about this when Nature came up with like this publication of the Human Genome Project. So it kind of started, they started the planning, I think in like the 1984. It was like formally launched in the 1990s, I think exactly at 1990. And then it was declared pretty much complete on April 14th, 2003. And the whole goal of this project is they wanted to map the nucleotides contained in a human haploid reference genome. So that's more than 3 billion nucleotides. And you have to remember, like, each person has their own unique genetics. So how do you make one single kind of reference genome? So what they ended up doing is they just took genes from all these different people and they created a mosaic. So they just spliced them together, and now like this reference genome is just this mosaic of all these different individuals. So it doesn't represent one individual, it represents all these different individuals from all these different ethnicities. And by the way, I just looked at like how much this cost, because the way they sequenced it was like very labor intensive. But it cost $2.7 billion in the fiscal year of 1991. So just imagine like $2.7 billion in the 1990s. Like that was quite significant. And it's still kind of being improved. So there's this website called the Genome Reference Consortium, and they're just kind of trying to improve it. And apparently there are 78 unresolved gaps. So although it was formally announced as complete in 2003, there's just like a few little tweaks that need to be done to it. But what's really interesting, so like this whole Human Genome Project, they used like pretty much like Sanger sequencing methods, and I won't go into like all the details of how things are sequenced, but let me tell you, like this process is like very, very labor intensive. And it's like one of like the really early types of sequencing. And throughout the years, like ever since then, we actually made these insane leaps in how we sequence DNA. And this is like the speed of sequencing, kilobytes per day. We kind of, like in the early 90s, 2000s, we were like way down here. It was like, 100 kilobases per day. And now we're like at just something insane. And it's just increasing every single day with the new technology. And with these increasing speeds of sequencing, we also get a decreased cost. So this is really big in medicine because, especially in Canada, like we want healthcare to be free for everyone. We want everyone to have access to it. So the fact that the cost of having your genome sequenced is about to dip below 1,000, that makes it like accessible to everyone. So it's not like we have this fancy technology that's only going to serve the wealthy and the rich. This is a technology that can be used for everyone, because the cost is just becoming so much more affordable. And just the amount of like research that's being done, you can imagine like there's so much information, there's so many nucleotides, and there's so many identified genes. It's like, how do you even make sense of all this stuff? And that's kind of where artificial intelligence comes in. It's like we can do all the experiments we want. It's just the amount of information that exists in the human genome is just so difficult for the human mind to comprehend. And the amount of studies that are being released, experimental studies, is just insane. We have to use some sort of like smart technology, something that's able to take all this information and just produce something useful from it. And this article was pretty interesting. So artificial intelligence in clinical and genomic diagnostics, they're basically saying like AI is already here, and we've been using it for a long time. We have all these methods, like for image recognition and for um, like all these natural language processing things. And these methods already exist. They can just be used. They can be extrapolated and used in genetics. The methods exist. We just need to know how to apply them in the right way. In genetics, you can imagine there's something called the curse of dimensionality. And what this means is you just have so many features, even if we don't look at nucleotides, if we just look at genes, there are like over 20,000 genes. And most sample sizes, if you have a group, like let's say you have 10,000 people, 10,000 patients described by 20,000 features, like you have way more features than patients. And you have to find a way to take all this data and somehow make use of it, because even computers can get confused. Even like artificial intelligence programs can get confused. So how do you condense all this data to produce some actually useful results? And they kind of explore this in this paper. And I always like to integrate just like real world company things, because I think it's interesting how there's all this research being done, and there's some people who are actually using it. They actually have a company and they're using it in real life. And I think that's always really exciting. So deep genomics, they focus on something called steric blocking oligonucleotides. And it's like the genetic determinant of some diseases at the level of RNA or DNA. So they look at these, and these are kind of like the diseases they picked, and they're just basically analyzing them using AI and these steric blocking oligonucleotides. So just some notes, like we talked about psychiatry, we talked a lot about precision medicine, and just remember, precision medicine, if we are going to use AI tools, we need to make sure we have a lot of data, first of all, and of the data that we have, it has to be diverse. And I showed this slide already, but if you don't have diversity of data, you cannot make like a legitimate AI algorithm that can uniquely predict things on a small population. So again, the GTEx portal, it's a great resource, but if you look at the actual people in it, most of them are white. If you wanted to make predictions on Asians, like they're such a small subgroup of this actual data set. So if someone of Asian descent, or even like American Indian or African American or whatever unknown descent comes in, how can you use your tool to make predictions on them, precision predictions, if your AI didn't train on data that was fit for that group? So it's always really, really important to think about what kind of data you're using. And this kind of comes with a push of explainability. So if we're going to use AI tools to make predictions that could possibly be life-changing for a patient, we need to have like some sort of thing that tells us, here is why we made these predictions. Here's why we think you need this treatment or whatever. Because how can I trust you? And this is like a whole debate, and I'm not going to talk about it too much today because it is a topic in the outro lecture that I'm sure the outro lecturer is spending a lot of time preparing for. But that becomes just so important in precision medicine. So in summary, we talked about psychiatry, lots of unstructured data in psychiatry. Some kind of tries to standardize it using a mini mental exam and the DSM-5 criteria. And then we just talked about personalized medicine. So individualized risk assessment and therapy plans on an individual to an individual basis. And then we had this data explosion with genetics. And remember, data diversity is very important, and consider possibly explainability. Why did the AI tools make the decisions that they did for this specific person? So thank you so much for listening. I really appreciate your time. If you have any questions about anything I said, please contact me via email. Otherwise, I am more than happy to answer your emails. Thank you so much.